Today's topic for the class is periapical pathosis. This class will be learning about what are periapical lesions, to know their classification, to understand how to understand their etiology, diagnosis and the treatment plan for periapical lesions. Now, have you already seen what is pulpal pathology is? Periapical pathology or periapical lesion is nothing but an extension of pulpal pathology. Now, as a consequence of pathologic changes in the dental pulp, the root canal can harbor numerous irritants along with bacteria. Now, egress or the extension of these irritants into the periapical tissues can initiate periradicular lesions. Depending on the nature and quality of these irritants as well as the duration of the exposure of the periapex to the variety of irritants can lead to a periapical lesion. Now, if you see this diagram here is very clearly explained. Now, since it is periapical lesion, I will be starting from the pulpitis stage. As I said earlier, it is an extension of the pulpal pathology. When pulpal pathology is not treated at that stage, it will extend to the periapical pathology. So, we will start with pulpitis, that means the inflammation of the pulp. It could be acute or chronic. I am sure all of you know what is acute and chronic is. Acute means of the shorter duration, chronic means longer duration. So, pulpal inflammation, whether it is of shorter duration or longer duration, can lead to apical periodontitis. That means an acute pulpitis will go into a chronic pulpitis, then from chronic pulpitis it goes into apical periodontitis. Now, when I say apical periodontitis, that means it is an extension of the pulpal pathology into the periodontia. Now, again it could be acute and chronic. That means when it is shorter duration is called as acute apical periodontitis, and when it is of a longer duration is called as a chronic apical periodontitis. Now, from that stage of periodontitis, that is inflammation of the periapex, it can become a periapical abscess or a periapical granuloma, periodontal cyst. Then the extension of this inflammation from the periodontium to the bone called as osteomyelitis, that is inflammation of the surrounding bone. Again it could be of shorter duration called acute, or a longer duration can become chronic. From there it can become periostitis, cellulitis or an abscess. This is the scenario or the process how the infection or the inflammation extends. Now, coming to the various classifications. I am sure in all lesions of dental origin, they have a classification done by many authors. Now, we will see it when it asks the major question, we expect you to write at least two classifications. So, we will see one of the classification by a gentleman who has done a lot of work in endodontics, Grossman sir. Now, he classifies them as acute periradicular diseases, chronic periradicular diseases with areas of rarefaction, then condensing osteitis, external root resorption and diseases of the periradical tissues with non-odontogenic origin. That means origin of non-dental origin, right. Now, coming to acute periradicular diseases, it could be acute alveolar abscess or acute apical periodontitis. Now, acute apical periodontitis means just the inflammation which could be in relation to a vital tooth or a non-vital tooth. Then it proceeds to a stage called as acute alveolar abscess. Then comes as the duration increases, it becomes a chronic lesion, again which is divided into chronic alveolar abscess, a granuloma or a cyst. Then, as I said in the previous in a slide, I explained to you all how the infection or the inflammation extends to the bone, it becomes a condensing osteitis. That means there is a inflammation of the bone surrounding the tooth called as condensing osteitis. Then it can lead to external root resorption, then diseases of the periradicular tissues of non-endodontic origin. This is how the Grossman classifies them. Coming to another classification by Engel, another gentleman who has done extensive work in endodontics. Now, based on the clinical signs and symptoms as well as the radiographic findings, he makes a very simple classification, three main clinical groups. One is symptomatic apical periodontitis, second is asymptomatic apical periodontitis, third is apical abscess. Simple. When I say symptomatic, it means patient has symptoms like pain, swelling and all these. They are called as symptoms. So, these are symptomatic apical periodontitis. Then asymptomatic one. Now, asymptomatic patient does not have any symptoms. That means it has passed the stage of symptoms and gone into an asymptomatic stage. Okay. So, this is basically identified by the clinician because patient does not have any complaint or symptoms where it can bring him to the clinic. So, you would have come for something else, you will identify it, okay, because the patient does not have any symptoms. It is called as asymptomatic apical periodontitis. Third one is called as apical abscess. This is a very simple classification by Engels. Then you have another classification by Veins. Now, Veins classification again is extensive. He classifies them as pulpo-periapical disease. One is painful pulpo-periapical pathosis, second is non-painful pulpo-periapical pathosis. Now, if you compare this with the previous one, Engel used the term symptomatic, Veins used the term painful. In this case, again, Engel used the word asymptomatic, Veins use the word non-painful. So, under painful, you have incipient acute periapical periodontitis. Second is called as the advanced acute periapical periodontitis. Now, under advanced acute periapical periodontitis, you have acute periapical abscess, recrudescent abscess and subacute periapical abscess. Under non-painful pulpo-periapical pathosis, you have pulpo-periapical osteosclerosis, then you have incipient chronic periapical periodontitis, then third one is called advanced chronic periapical periodontitis. Under advanced chronic periapical periodontitis, you have three classifications which is divided as periapical granuloma, chronic periapical abscess and periapical cyst. Coming to the next classification by WHO, it was done in the year 1995. They give the coding like K04.4 to K04.82. Now, K04.4 is acute apical periodontitis, K04.5 is chronic apical periodontitis, also called apical granuloma, K04.6 is periapical abscess with sinus, 0.60 is periapical abscess with sinus to maxillary antrum, 0.61 is periapical abscess with sinus to nasal cavity, 0.62 is periapical abscess with sinus to oral cavity, 0.63 is periapical abscess with sinus to the skin. Now, and then you have K04.7 called the periapical abscess without sinus, 0.8 radicular cyst, 0.80 is apical and lateral cyst, 0.81 is residual cyst and 0.82 is a inflammatory paradental cyst. This is how the WHO classifies them. As I said earlier, for a major question, you can write any one of these two of these four classifications. Now, coming to each of these conditions, first let us start with acute alveolar abscess. It is also called as acute periapical abscess, acute dentoalveolar abscess. Why I am writing this synonyms? Basically because when a question comes, it could be asked as explain acute periapical abscess, or they might say explain acute dentoalveolar abscess or acute alveolar abscess. All means the same. Now, how do you define them? It is defined as a localized collection of pus in the alveolar bone at the root apex of a tooth following death of the pulp. with extension of infection through apical foramen into the periradical tissues. It's very clear. It is an extension of the inflammation and infection from the pulp to the periapex through the apical foramen. So, localized collection of pus in the alveolar bone at the root apex of tooth following death of the pulp with extension of the infection through the apical foramen into periradicular tissues. What are the etiology? Etiology could be trauma, chemical irritation or localized irritation. See the picture there, it's very clear. There is a swelling there. When you take a radiograph, you can see periapically lesion, you can see, or widening of the lamina dura there. Now, if you see the histopathology, of course, in clinical scenario, you cannot take a biopsy and see that, but if at all you take a biopsy, what do you see in the histopathology? You can see polymorphonuclear infiltration into the area, accumulation of inflammatory exudates, there is a distension of the PDL space or the periodontal ligament. Distension means this widening. What we normally see when you take a radiograph, you see the widening. As I said earlier also, if I can go back to that, earlier I said in the radiograph you can see widening of the PDL. That's what exactly I was telling there, is a distension of the PDL. Process, when it continues, the PDL separates. The PDL gets separated from the root. So, when this happens, when the periodontium gets separated, the tooth becomes mobile, or there is a mobility happens. And this is followed by the bone resorption at the apex. Then there could be liquefaction necrosis and cell, if you see the cell remnant and exudate. That's what you see in the histopathology. Now, what are this? Now, as I said earlier, when the patient comes to you, it is not that you're going to take a biopsy there, but if at all you see take a biopsy, that's what you're going to see in the histopathology. But what we see in the clinic is the symptoms. The first symptom could be tenderness. Patient notices that that particular tooth is not normal. When he bites or when he touches, there is some pain or tenderness, telling that there is some deviation from normal has happened. Now later, patient has severe throbbing pain with swelling of the overlying soft tissues. That is, when the exudate collects in the area there, patient has throbbing pain with swelling of the overlying soft tissue, which if you can coincide or relate to the early histopathology. Now, as the infection progresses, swelling becomes more pronounced and extends beyond the original site. Now, as the more inflammatory fluid collects, or if the pus extends beyond the area, then it gets spread into the area there. Tooth becomes more painful, elongated and mobile. When I say elongated, I mean the tooth does not become longer, but tooth can prop up from its own socket. That means when the patient bites, that particular tooth touches first before he touches the other teeth in occlusion. So when this happens, the patient immediately feels pain. So he will stop using that side. If untreated, progress to osteitis, periostitis or cellulitis. And there could be, as I said earlier, there could be collection of the pus there, which finally when the resorption of the bone happens, and it could come in the form of sinus. That's a slight opening. If you see in the picture there, you can see there the sinus opening to the buccal mucosa there. Now, when maxillary anterior teeth is involved, the swelling of the upper lip and chin, you can see the picture again. When maxillary posterior teeth are involved, the cheek may swell. That's, you can see the picture on the left side. That's where the swelling of the cheek is there. And on the right side, you can see with the anterior teeth is the swelling of the upper lip. Then when the mandibular teeth are involved, or the mandibular posterior teeth are involved, there is swelling extends around border of the jaw into the submaxillary region or the ear. Now, when the sinus is there, when clinically patient presents himself or herself with the sinus, you can trace the sinus, you can take a number 25 or number 30 Gattapacha point, and through the sinus opening, you can place the Gattapacha and then take a radiograph. Now, if you see the clinical picture there, what on the left side you can see there, with the Gattapacha placed into the sinus and the radiograph is taken from the same tooth, you can see the radiograph is leading to the same tooth. So, they can identify which tooth has resulted in the or the sinus has resulted because of infection of which tooth. That can be identified very clearly. And beside this, there could be general systemic reaction is seen, like patient appears pale or irritable, he could be having fever, and because of loss of sleep is highly irritated or irritable. So these are the general features other than the dental symptom what he can come or present himself in the clinics. Now coming to the diagnosis, the early stage it is difficult to locate because unless the periodontium is involved, as we know, the proprioceptive fibers or those nerve fibers which are responsible for the position, they are present only in the periodontium, not in the pulp. So till the inflammation or the infection reaches the periodontium, in the early stage it is difficult to locate the tooth. Once infection progresses to process of periodontitis and extrusion, a radiographic evaluation shows thickening of the periodontal ligament, space and breakdown of the bone. If you see a pulp test, whether it is electric pulp test or a thermal test, there is no response. Tooth is tendon, if it percusses the tooth, this tendon on percussion. Most of the times, we don't even have to percuss. If you touch the tooth, there is palpation. Okay, itself, patient will have jump with pain. Apical mucosa is tendon on palpation. There is on the buccal side of the tooth involved. If you touch there, palpate that the apical mucosa there tender because of the collection of the pus. Tooth may be mobile and extruded. I use the word elongated that time. That is other words called extruded. That means because of the inflammatory fluid collection or the pus collection at the apex of the tooth gets pushed itself in from its own socket and it may be mobile and extruded. Differential diagnosis could be periodontal abscess and irreversible pulpitis. This is about the alveolar abscess. The treatment would establish drainage and control systemic infection. On the first visit, tooth is left open for drainage, thorough instrumentation and irrigation before medicating and sealing it. Once the swelling and pain subsides, endodontic treatment is done. If diffuse swelling is there, put the patient on antibiotic coverage along with hot mouth rinses so the area gets localized. Once the area is localized or when the pus gets localized to the area of concern, you can incise and drain the pus. Coming to the next condition called as the acute apical periodontitis. Now, acute apical periodontitis is nothing but a painful inflammation of periodontium as a result of trauma, irritation or infection through the root canal, regardless the pulp is vital or non-vital. Again, so it's a painful inflammation of the periodontium. Where it has come from? From the pulp itself. So it's a painful inflammation of the periodontium as a result of the trauma to the tooth, irritation or infection to the pulp, and this inflammation is spread through the root canal regardless whether pulp is vital or non-vital. Now, the gentleman called as P.N.R. Nair, who has done extensive studies on histopathology, he classifies them as acute apical periodontitis, that is either primary and secondary, chronic apical periodontitis and cystic apical periodontitis. It's also called as true cyst. Now coming to etiology, it could be, as I said earlier, it could be occlusal trauma, wedging of the foreign object between teeth, non-vital tooth as a sequelae to pulpal diseases, iatrogenic, that is during over instrumentation and extrusion of the irritating medicaments. When I say iatrogenic, that means induced by the clinician. Okay. Now, induced means not that he wanted to induce it, but it can happen during treatment. That is either due to over instrumentation or extrusion of the medicament what is used in the intracanal medicament. It could be irritating the pulp. That can also cause apical periodontitis. There, of course, the perforation of the root. Symptoms: pain and tenderness. Tooth may be slightly sore when percussed. Now, if you see the histopathology, of course, histopathology is only of interest when when you take a biopsy there. But if at all you take a biopsy, obviously we are not going to take a biopsy a clinical scenario. It's always a clinical symptom. But if you see the histopathology, what is going to see? There is an inflammatory reaction in the apical periodontal ligament. Blood vessels are dilated. PML, that polymorphonuclear leukocytes are present. Cholesterol clefts are the common finding, and there could be accumulation of serum exudate in the periodontal ligament area, and osteoclast is seen. Osteoclast which is going to resolve the bone, osteoclast is seen. This is what you are going to see in the histopathology. Now coming to the diagnosis, tooth is tender to percussion. Symptoms are due to over-instrumentation, irritating medicament or overfilling. Radiographically, thickened periodontal ligament or small area of rarefaction. Treatment, endodontic therapy. Postoperative pain is controlled with analgesics and antibiotics, and if hyperocclusion is there, occlusion has to be reduced. Coming to the third condition called as phoenix abscess, also called as acute exacerbation of a chronic abscess. That means originally the condition is a chronic abscess. Due to some reasons it has turned acute, or originally the reason is non-symptomatic or asymptomatic, but it has become symptomatic due to some conditions called as phoenix abscess. It is an acute inflammatory reaction superimposed on an existing chronic lesion such as a cyst or a granuloma. Now what is the etiology for that? Etiology could be noxious stimuli from a diseased pulp with chronic periradicular disease. Because of the influx of the necrotic products of the bacteria and their byproducts, the dormant lesion may become reactive and cause an acute inflammatory response. Third could be the lowering of the body's own defense or the immunity can also trigger an acute inflammatory response. And lastly, the mechanical irritation during root canal treatment or instrumentation. So the four etiology or the cause are the for phoenix abscess, as I said earlier, it could be noxious stimuli from a diseased pulp with chronic periradical disease. It could be influx of the necrotic products, bacteria and their byproducts or the toxins from a dormant lesion may become reactive and can cause an acute inflammatory response. Third is the lowering of the body's defenses or the body's immunity, and lastly a mechanical irritation during root canal instrumentation. Symptoms: tooth tend to be elevated in its own socket and painful. Mucosa surrounding the tooth could be appears red and swollen. Again, if you say take an histopathology there or a biopsy there, you can see liquefaction necrosis with disintegrating polymorphonuclear leukocytes and cellular debris, that is pus. And these PMNLs could be surrounded by infiltration of macrophages, lymphocytes and plasma cells. Now what does macrophage and lymphocytes say? They are basically chronic inflammatory cells. That means the lesion was originally chronic with the macrophages, lymphocytes and plasma cells, which are chronic inflammatory cells. Suddenly there is an acute stage resulting in the appearance of PMNLs. Diagnosis based on the history of the patient or the vitality test. Vitality test, normally the tooth is non-vital, and if you take history, patient can give a history where it could have a longer duration because originally the condition was chronic. Differential diagnosis could be acute alveolar abscess, acute irreversible pulpitis. Treatment: establishment of drainage. Once symptoms subside, root canal treatment is done. Now coming to chronic alveolar abscess or a chronic suppurative apical periodontitis. Definition: a chronic alveolar abscess is a long-standing low-grade infection of the periradicular alveolar bone. It's a long-standing low-grade infection of the periradical alveolar bone. Etiology: depth of the pulp with extension of the infective process periapically, or it could be a pre-existing acute abscess. What are the signs and symptoms? Generally, when it is chronic, symptoms are, it is asymptomatic. It is detected either by the presence of a sinus tract or on routine radiograph. If the sinus tract drainage becomes blocked, pain and swelling could be there. Otherwise, generally there is asymptomatic or there is no pain and swelling. Range of sensitivity to percussion and palpation depends on the sinus tract, whether it is open or blocked. As I said earlier, it is asymptomatic. If at all it turns symptomatic because of the blockage of the sinus, existing sinus, it will be painful, or else it is non-painful. You can, of course, you can through the sinus tract, you can push the guttapacha there, you can see the picture there and take a radiograph. It tells you which tooth is the one which is causing the sinus, or which will be able to identify which tooth is having this chronic alveolar abscess. Diagnosis: chronic abscess may be painless or mildly painful. First sign is osseous breakdown. If you take a radiograph, you can see there is a, on routine exam, for some reason if you take a radiograph, you can see there is a large lesion associated with the tooth which is non-painful or asymptomatic. Patient may give the history of sudden sharp pain which subsided and has not recurred or reoccurred. Clinically, a large carious exposure or a composite filling or an acrylic filling or a metallic filling or restoration or discoloration of the crown of tooth. So, clinically, see, patient won't have come for that particular condition. For something else would have come. On routine examination, you can find out this, and you find it could be a large carious exposure in a particular tooth, or there could be a large composite or a acrylic or a metallic filling in a tooth which is discolored, but patient is asymptomatic. You take a radiograph, you can see a large lesion, and this could be a chronic abscess condition. So, radiographically, a diffuse area of bone rarefaction, periodontal ligament is thickened. Vitality test, if you do, they are negative, that means the tooth is not responding to histopathology. If you see, periodontal fibers at root apex are detached or lost. Apical cementum is maybe affected. You can see chronic inflammatory cells like lymphocytes, plasma cells at the periphery, and PMLs at the center. Fibroblasts form a capsule at the periphery. Treatment: endodontic therapy. The sinus tract ultimately heals by granulation. When sinus tract does not heal while the tooth is under endodontic treatment, it will be cured with a small spoon excavator. So, when sinus tract does not heal while the tooth is under endodontic treatment, it can be cured out to remove the granulation tissue with a spoon excavator, and it will heals by after that. Thank you for a patient hearing.